Previously today, we've heard a nice overview on the issue presented by Professor Robes, and we've heard ambitious plans for Georgia. However, let me now show you a kind of optimistic scenario which has already been going on in a real-life setting. So we know that over Europe, the seroprevalence of HCV infection varies among the countries from 0.4 to 5.2%, depending on being in the north or in the south of Europe. And we also know that actually people who inject drugs are the driving force of HCV epidemic nowadays, because the ECDC report from 2012 shows clearly that 78% of newly infected among European countries reported IV drug use as the mode of transmission or of infection. And according to the European Monitoring Center for Drugs and Drug Addiction from 2013, it's very clear that the seroprevalence of HCV infection among various European countries varies from below 20% to up to nearly 90% in some particular European countries. And the studies have shown that the proportion of co-infected with HIV varies among countries. We've heard some very updated data and figures from the CEE countries today in the morning. But the meta-analysis of published studies until 2014 has clearly shown that there is a great proportion of HCV undiagnosed people who inject drugs among European countries, going up to even 59% in the United Kingdom, and definitely being quite high in the CEE region as well. And interestingly enough, according to the EMCDD report from 2013, there has been also in some particular countries a very high HCV seroprevalence among new injectors, in spite of all the known methods of prevention strategy. Because the studies have clearly shown that HIV prevention programs are effective also in reducing transmission of HCV. However, in spite of that, HCV incidence, as you know, remains fairly high, even in areas with such programs, and the risk of HCV among people who inject drugs is even higher in some developing countries. We are all familiar with these strategies to prevent HCV transmission, and due to all these new figures and new infections, two new strategies have been proposed for the prevention of HCV transmission, which is quite similar to HIV infection. And these two strategies are actually testing and treatment for prevention. Do they work? Well, of course, testing in people who inject drugs, as you know, works, because it works on the individual level. If you get testing, you can get linkage to care, and you can get a cure, so it prevents morbidity and mortality due to HCV. However, the epidemiological studies have shown that if you screen and counsel regarding the HCV infection, you may reduce the risk behavior in uninfected as well as in chronically infected, and these measures are definitely cost-effective. And another study has shown that the notification of being HCV positive in people who inject drugs leads to significant reduction in subsequent drug use compared to those who tested HCV negative. So testing definitely works for prevention. What about treatment? Of course, it works on the individual level. It may lead to cure, and it lowers morbidity and mortality related to HCV. However, the modeling studies have shown that treatment also works on the epidemiological level, because the study of Martin and Matt Hickman has shown that even modest rates of HCV treatment may effectively lower HCV prevalence, even in scenario with reinfection and even in treatment failure. And another recent study has shown that if you combine HCV treatment with needle and syringe programs and opiate substitution treatment, you may have a more than 50% decrease in prevalence over a 10-year period. So actually, treatment also works as prevention. So based on all these facts, it's quite obvious that the management of HCV infection in people who inject drugs should be complex. It should integrate all the three strategies: prevention, testing, and treatment. However, a meta-analysis of all the studies on entering antiviral treatment in observational studies in non-clinical settings has shown that the proportion of HCV positive drug users as well varies among European countries, is very low, and of course it's highest in France, which, as you know, is a kind of El Dorado for treatment of HCV infection. Why is that so? Well, let us admit, all of us, there is a kind of reluctance to treat HCV infection in people who inject drugs due to several barriers. Barriers from the side of the patients, the practitioners, the system. There are no national strategies, action plans on clinical guidelines on treatment of HCV infection in drug users. As you know, there are concerns of severe adverse events, non-efficacy, poor adherence, reinfection, and so on. Even in 1999, the EASL guidelines stated that actually HCV treatment is contraindicated in active IV drug users. And we all know, and let us admit, that treatment with interferon is complex due to mode of administration, duration, adverse events, adherence, need for frequent follow-up visits. Of course, it's not 100% effective, and of course, it's not very cheap. However, several studies from various parts of the world have shown in the recent years that even treatment with PEG interferon RIBA works in people who inject drugs. It is quite comparable to general population. It is safe, it is effective. Treatment uptake is effective and even cost-effective, also in low threshold settings. And that the history of intravenous drug use does not compromise neither adherence nor treatment completion, and vice versa. There's no influence on HCV treatment on increase in drug use or treatment of drug use. And of course, the major obstacle, the reinfection. Studies have clearly shown that after successful treatment, reinfections are rare in people who inject drugs. They happen in 1 to 5% per year, or which are the latest data from Hill and co-authors from this year's CROI. There is at most 30% of reinfection in a 5-year period in people who inject drugs. But with all these new direct-acting antivirals, with more than 90% effectivity, interferon-free treatment, which is well-tolerated, safe, suitable for drug users, as we've seen today, with all oral, once daily, short duration, and so on, actually, treatment in people who inject drugs should definitely not be a problem. However, as you know, every rose has a thorn, and the thorn in this case, of course, is a cost. Here are the costs or the prices of these new drugs at approval. And such a price, or a $1,000 pill, is difficult to swallow even for the United States. And actually, it is difficult to be swallowed by an active drug injector because it may bring about more reluctance from practitioners and actually more stigmatization from the population at large. However, all the most distinguished medical institutions, as you know, call for HCV treatment in people who inject drugs, as we do, I'm sure, in this room. So it is the EMCDDA guidelines, WHO from last year, EASL guidelines, and the latest guidelines from this year, April this year, from Vienna, also speak in favor of treatment. We've already seen this recommendation from EASL. Actually, active injectant drug users were put into the group of prioritized treatment with DAAs due to the high risk of transmission. However, this is an expert personal opinion from EASL this year, what should be a precise list of priorities? And as you see, number one, first should be treated those who are who carried the burden of disease threat, meaning the F3, F4 stage of fibrosis, then followed by those who are at public health threat, meaning the IV drug users, and then all the rest should get treatment. However, the EASL guidelines also state that HCV treatment should be delivered within a multidisciplinary team setting with experience in HCV assessment and therapy. So, we've come now to an integrated approach, which is the best approach for managing HCV infection in people who inject drugs, being shown by several studies in the recent years. But you don't need new facilities. You can actually use the already existing services to implement this integrated approach. Either this is a hospital-based clinic or community-based clinic or drug detox clinic or prison or whatever. And in that way, a kind of multidisciplinary team arises, including viral hepatitis specialists, psychiatrists, addiction specialists, peers, other supportive team, counselors, and so on. And such an integrated approach, so actually, if you don't have the facility, it needs to build it, but if you have it, it just needs to integrate public health capacity and clinical provided capacity. But above all, you need to have a national strategy, action plan, and basically you need national clinical guidelines for the management or treatment of hepatitis C. And so in 2013, we performed a study on 33 European countries regarding the national level activities on HIV management with the question on people who inject drugs. And we found out the respondees of the questionnaire that was included into the study were not the main authorities or the people from ministries of health, but the respondees were those professionals who were mostly motivated and most deeply involved in the problem of treating HCV infection. And so we found out that out of 33 European countries, only 12 in 2013 had national strategy for the management of HCV infection. However, only 11 included management of people who inject drugs. As for action plan, only 10 countries reported on it, only 7 involved people who inject drugs. And 24 countries had treatment guidelines. However, only 20 out of 33 reported on having clinical guidelines also for the treatment of people who inject drugs. So how is my country, Slovenia, managing this problem with treatment of HCV in drug users? It is a pocket country of 2 million of inhabitants with an estimated HCV RNA prevalence of 0.3%. There are around 10,000, estimated 10,000 drug users, 6,200 being on opiate drugs. The seroprevalence of HCV infection was estimated 23%, which is third the lowest among European countries according to the EMCDD report from 2013. And this is most probably the reflection of early introduction of harm reduction programs in Slovenia in the early 90s and early introduction of opiate substitution treatment into the country as well. Interestingly enough, there is a very, very low prevalence of co-infected with HIV, most probably due to the fact that the vast majority of HIV-infected patients in Slovenia are MSM, whereas on the other hand, the vast majority of Hep C patients are actually people who inject drugs. Well, how do we manage hepatitis C in Slovenia? There is an integrated approach. This is a kind of policy how to do it. This is an integrated approach of 2 major institutions, National Institute of Public Health and National Viral Hepatitis Expert Group, which is actually a crucial institution for overcoming the problem. The first one works under the Ministry of Health. It relies on law on communicable diseases, takes care of surveillance and harm reduction strategies, but the National Viral Hepatitis Expert Group was a self-founded institution of interdisciplinary team of highly involved professionals, and this is the one that set up the national strategy, action plan, and consensus clinical guidelines. And here are some milestones in Slovenia of managing Hep C infection. So the group, the expert group was founded in '97, and already in '97 in Slovenia, a national strategy was set up for the management of HCV infection together with clinical guidelines. So the guidelines were updated several times regarding the currently recommended treatment of care. However, in 2007, a focus was made on the group of people who inject drugs, and the National Healthcare Network was set up just for the treatment of Hep C infection in drug users together with national clinical guidelines. Since there were no new drugs on horizon for 10 years except for PEG interferon RIBA, in 2008 we made a clinical guidelines for the maximal optimization of treatment of Hep C using EPO and so on. And now with the upcoming of new DAAs, of course, the new national consensus guidelines were performed. And this year we made a financial assessment of the burden. We made a modeling approach also towards the elimination of the disease. These are the drugs that are available in Slovenia. Boceprevir and tenofovir are no more used due to the new DAAs. We are just about to get ledipasvir plus sofosbuvir. And the most important thing is that all the treatment is completely reimbursed or financed by the public health insurance system with no limitation except for one. It has to be prescribed by the nominated specialist and according to the national guidelines. And in December last year, actually, we updated the guidelines regarding the DAA with a prioritized group, the first one being those with F3, F4, and followed by those who are dangerous for transmission of infection. And in Slovenia, we do have a national register of all the treated patients actually since 1997, and we do the evaluation of treatment efficacy and safety. There are 5 centers for treatment of HCV in Slovenia. It's done in majority of cases by infectologists. And actually, as I said, the focus has been made on drug users. Drug users in Slovenia are managed at 18 centers for prevention and treatment of drug addiction around the country. And around 5,000 have been managed in those centers every year. This is nearly half of them. And in 2006, we made a study and found out that only 3% of those who are HCV RNA positive got treatment for HCV. So something was wrong, something needed to be done. And that's why we did a national healthcare network for the treatment of HCV in drug users. No extra money was needed, nothing, no extra personnel. We just combined or integrated already existing facilities of 18 centers for treatment of drug addiction and 5 centers for treatment of viral hepatitis. And in that way, a multidisciplinary team arose of all the specialists. This is a team of 150 people, various professional, stages of profession, various specializations. There are nurses, there are peers, there are virologists, pharmacists, psychiatrists, whatsoever. And every year we exchange our experiences, especially dedicated symposia. And also in 2007, special clinical guidelines were set up for the treatment of HCV in drug users. And it's very clearly defined which tasks should be performed in uninfected, acutely infected, and chronically affected, and where should they be performed. And all these centers work in very close cooperation. So what have we achieved by introducing these systems? After the implementation of strategy, network, and guidelines, as you can see, in merely 2-year period, we increased the treatment of HCV-infected drug users by 10%. Or if we have a look at it from another point of view, as we see here are the 4 studies on treatment success regarding the currently recommended standard of care. The first, in interferon period, of all the patients in Slovenia, only 5% were drug users. The second period, interferon riba, of all the patients that were treated in the period 99 to 1, only 16% were drug users. But after the introduction of National Healthcare Network for Drug Users, of all the treated patients in Slovenia in the period 2008-2010, actually 78 reported drug use as a mode of transmission. Was the treatment successful? Of course it was. With the optimization of treatment, be aware, this is a PEG interferon riba, we got all over 82% of sustained virological response, and only 4.3% were non-adherent. These are drug users, actually. But another study showed extraordinary results. We just recently checked what happened after the drug users when they got sustained virological response. And we found out that after successful HCV treatment, a significant change in lifestyle came out in terms of residence, in terms of employment, and in terms of education. This is the first study of the kind that was presented, and moreover, after successful treatment of hepatitis C, there was a significant cessation of active drug use among those participants. So, if we compared this integrated approach, as I presented you, to the studies analyzing other approaches, such as only approach in drug treatment center with drug treatment specialists, or only approach with hepatitis centers separately from drug treatment specialists, then you can see that actually the integrated approach shows the highest all-over sustained virological response, and it shows also the lowest non-adherence in population. But we wanted to look into the future, so we made a kind of modeling approach towards the elimination of HCV infection in Slovenia. We used the Homi-Razavi approach from Center for Disease Analysis, which has been presented today by Professor Rockstroh. And actually, you can see that if we use just this model includes the whole population to be treated for hepatitis C, of course including also drug users. And if we use just the current diagnosis and treatment rate, as you see, by 2030, we'll get just a 22 decrease from this year in prevalence, and we'll get a 25% increase in end-stage liver disease. However, if we play with figures and statistics a little bit, and we slowly increase the diagnosis rate to come to 700 new diagnosed patients in 2026, and we increase slowly the treatment rate, so by 820 per year in 2026, then we can find the scenario in purple, meaning that by 2030, we'll get a 90% decrease in prevalence, 84% decrease in decompensation rate, and 77% decrease in liver-related deaths. So, to conclude, ladies and gentlemen, I hope I persuaded you that an integration of improved diagnosis rate, enhanced HCV treatment efficacy, as well as improved treatment uptake, all the three of them may reduce HCV prevalence and HCV-related morbidity and mortality, and that integration of testing and treatment with already recognized preventive measures can additionally reduce HCV transmission in drug users. The provision of this integrated care is best to be done in a multidisciplinary team, but you can use already existing facilities, so actually you don't use extra funding or extra organization facilities. But a comprehensive national policy is definitely needed to set up national strategies, action plan, and clinical guidelines if you want to implement such an integrated management of HCV infection in drug users. Thank you very much.